Good evening and welcome to Conversations Live, Understanding and Preventing Suicide. I'm Patty Satalia. On average, someone in the U.S. commits suicide every 12 minutes. For every suicide, there are 25 attempts. Worse yet, rates for both are on the rise. Why are so many Americans taking their own lives and what can be done about it? Tonight, our experts will discuss warning signs and how to help someone who is suicidal. They'll also take your questions. Now, let's meet our guests. Marissa Visseri is the founder and president of the Jana Marie Foundation, which works to educate young women to combat depression, substance abuse, and suicide. She also serves on the executive committee for the Pennsylvania Youth Suicide Prevention Initiative. Shannon Quick is the director of crisis intervention for the Meadows, a behavioral health treatment facility. She's also chair of the Center County Out of the Darkness Walk to fight suicide. It benefits the American Foundation for Suicide Prevention. And Dr. Timothy Durstein is chair of the Behavioral Health Services Department at Mount Nittany Medical Center. He specializes in adult psychiatry with interest in bipolar disorder and treatment-resistant depression. Thank you all so much for being with us. You can join tonight's conversation. Our toll-free number is 1-800-543-8242, and our email address is connect@wpsu.org. You may also tweet your question or comment to WPSU Connect and use hashtag WPSU Conversations. So I'd like to begin by getting each of you to explain your role in helping us to understand and prevent suicide. Why and how, Marissa, did you become involved in all of this?
Sure. I got involved in 2011 after my sister died by suicide. So she took her life at the age of 30, and we wanted to do something in her memory and also to help other families know how to get help if they need it, and also how to protect them from some of the experiences that we had.
And I want to come back to your experience as a suicide survivor. But before we do that, Shannon, how did you become involved in this? What's your role in helping us understand and prevent suicide?
I'm the Director of Crisis Intervention Services for the Meadows and UCBH. And in my role, actually, I manage crisis services for 10 counties in Pennsylvania. And I've actually done this for, this year will be 18 years that I've worked in this field. So something I'm very passionate about. I'm the chair for the Out of the Darkness Walk in Center County. And I actually also am a board member for the Adult and Older Adult Suicide Prevention Coalition for Pennsylvania.
What have you seen in the last 18 years in terms of changes? Because what I'm reading is, for many age groups, suicide is on the rise, and worldwide it's the third leading cause of death, which is absolutely shocking to me. 10th leading cause of death in the U.S.
It is, and through the years we have seen some dips in which it has lowered, but we do continue to see the rates of suicide on the rise, and individuals who struggle with mental illness, who really struggle with the access to care, how to get into treatment, how to talk about suicide, how to help their loved ones. Always that seems to be just something that people need help with, and how to really start that dialogue. And so through the years, our prevention efforts have gotten better, but we still really are struggling to make a dent and to really save lives.
Dr. Durstein.
I work as a psychiatrist locally, both inpatient and outpatient, and at least 90% of people who attempt suicide or do die by suicide have a mental illness at the time that that this is happening. And so in our role in assessing and treating people with psychiatric illness, we're very attuned to the risk associated with illness and suicide. In addition, comorbid drug and alcohol use disorders are frequently part of the picture, both in terms of increasing the person's risk for suicide, but also in the moments that they may be having thoughts of ending their life. Frequently, they're under the influence of alcohol or drugs at the time, which can potentiate or make it more likely for them to carry through with that.
I think it's worth noting that while depression is correlated with suicide, not everyone who suffers from depression is suicidal.
That's correct.
So how does one determine whether a loved one is suicidal or not? What are the red flags?
Without asking, one of the things that we can look at is changes in behavior, a person talking about feeling hopeless or feeling like life isn't going on, or talking about a sense of feeling cornered or trapped, or not feeling like they have a place to turn. Those are all kinds of things that should be a warning sign that this could be serious.
You said without asking, and I just watched a series of videotapes, candid conversations that the Jana Marie Foundation put out to prevent teen suicide. And one of the messages that was loud and clear to me was, do ask. If you have any inkling that something is amiss with a loved one, ask. And it's not a problem, apparently, to say, are you feeling suicidal? Come right out with what we call the S word.
Mm-hmm. Yeah, it's really important that we ask that question, and we ask it in those terms, or are you thinking about killing yourself? And that way we know what the intentions are, and we can ask some follow-up questions as well. Do you have a plan? Do you have access to a means? Really trying to figure out what the timeline is and how involved those plans are.
I think a lot of people hear that and say, I don't want to ask that kind of a question because I'm going to implant in their head the idea that I think they're going to do it, or even suggesting a way that they might do it. And tell us, Shannon, why is that not really a problem to come right out with it?
And that's actually one of the biggest myths about suicide, is that if I talk about suicide, if I ask about it, then I'm going to give that person the thought of suicide.
It's like sex education arguments.
That's right.
You know?
Exactly.
You're going to encourage a young person to have sex if you tell them how to safeguard themselves.
Exactly. And what we talk about is that you have to use the language. You have to be honest and authentic in that communication with people, and that it is okay to ask the question. I mean, actually, when we ask that question and someone says, yes, I'm having thoughts of suicide, that is a late warning sign. And we have to take all of those verbalizations very serious. And to talk about that, you might actually be the person who gives language to that person, or gives them the opportunity to admit and to talk about it. You give them the opportunity to recognize what they're going through and have them express themselves. So it's very okay to ask that question.
There's a wealth of information on the internet about suicide, but the overwhelming message that I got in everything I watched and listened to was people who are contemplating suicide, they want someone to listen. So I'm wondering, from you, Dr. Durstein, what role does medication play in treating depression, and how important are things like psychotherapy?
With each person, we evaluate them and come to a diagnosis or an impression of what's happening at the time, and based on what the history is. And depending on how severe the depression may be, or, for example, bipolar disorder is also a situation where someone is at risk, we will recommend medication therapy. Frequently, and I would say usually, psychotherapy would be a recommended treatment to go along if somebody would need medication. Some people don't need medications and really just need a therapist to help them work through and think through what they're experiencing.
And really learning coping strategies, because the problem is you're so overwhelmed by life stressors. And it could be anything. It could be a loss of a job. It could be a bad economy. It could be a loss of a girlfriend or a partner, those sorts of things that can put someone over the edge or at risk.
And I think what was being mentioned earlier about asking the question, frequently people may feel so alone or isolated or just really not sure how to reach out. And so someone asking them questions, seriously being interested in them, can be a real lifeline for them to begin to talk about what's really going on.
In fact, one quote that struck me, being alone and suicidal is a lethal combination. So be there for your loved one if there are any signs. And I want to get back to that in a moment. But we have Rhonda on the phone from State College. Rhonda, go ahead, please.
I'm listening to what you're saying, and I'm feeling like you've listened to this person and you've tried to help them, and done everything you can, and it feels like they're coming out of their depression. And then they attempt it again. I mean, what do you do?
What do you do? And that's an interesting point. I've read about a lot of instances where someone is presenting now, things seem to have cleared up, they're doing better, and yet they commit suicide. How common is that, Dr. Durstein, that it looks like they're coming out of a deep, dark place?
I think until someone has really moved to the point where, if it's depression, which is frequently the case, that's really been stabilized, I think there continues to be an elevated risk for suicide. So one of the things that I think for some people is helpful to think of suicide or thoughts of suicide as symptoms of the illness of depression. So if I had pneumonia, I would have shaking chills, and I would have a fever, and I would be coughing. For a subset of people, having suicidal thoughts or believing or thinking that I shouldn't be alive is part of what goes along with the illness. So if that's present, that tells me the illness is not in good remission, and it means that more needs to be done in terms of treatment.
But it can be devastating for a family because you can be fooled. You can be fooled into thinking that they've turned the bend. Can you tell us, and I'm going to take another phone call in a moment, but in your own case, Marissa, because you described June 18th, 2011 as the day you will never forget. Mm-hmm. Looking back, were there red flags that your sister was suicidal?
There were. She had attempted numerous times, starting around the age of 13. And, as you had mentioned, it's often kind of a side effect of the depression. And so as a family member, it's very hard. You want to get them all the help, and you want to be there for them, and it gets hard to be there for them at times because they have to help themselves somewhat as well. And but all you can do is be there, love them unconditionally, and offer a hand whenever you can, and just help them know that they're there, or that you're there to listen to them.
What can you add to that, Shannon?
I would say that one of the things is really embracing the fact that suicide is part of the illness. It is a disease. It is the illness. So with mental illness, that person, the suicide, thoughts can come out of that, major depression, that bipolar. They can be reoccurring illnesses in which the person can have periods in which they feel better and then periods that they don't. It does come back. And simply because an individual has gone through treatment, has done well, but if things come back, the complications of the illness, if they have, they've lost something, they lost a job, the medication doesn't exactly work, something else has happened, in regards to the brain chemistry or any of those different factors that affect us, the thoughts of suicide can reemerge, and they do reemerge.
Well, in Marissa's case, she said her sister first started talking about suicide at age 13, and I understand that the most risky point for someone who has attempted suicide is within a month of a suicide. Explain why that's such a critical time period, Dr. Durstein.
Prior to hospitalization, for example, and many people who attempt suicide or commit suicide or have an act of furtherance in some way end up being hospitalized. So the risk factors that led to the hospitalization don't go away quickly, sometimes don't go away at all. And so we're spending that time looking at which of those factors can be ameliorated or reduced, and what are some of the protective factors that can be identified and put into place. And in the hospital, for example, or in the outpatient office, we can start medication, but it can take 3 weeks, 6 weeks for the medication to really have an effect. So someone has come in and is in the situation of seeking treatment. That can be helpful, and that can be a step in the right direction. However, they may not be out of the woods yet.
The problems don't just suddenly disappear.
They do not.
And I think it's important for family members and loved ones to say the right things, not make light of how they're feeling. How they're feeling is absolutely legitimate. But that this may take time, that there is help, but it may take time. I'm just curious to know, what should you say?
Yeah, and I think just going back to what we've talked about is asking questions, is being there. People typically do not engage in suicidal behavior when they're with other people. It's when they're alone and when they're feeling isolated and disconnected. And we often, it can be hard to know what to say, but really the most important things, I think, are communicating caring, communicating that you're there, you're going to help in ways that you can. And frequently that may be calling crisis, that may be helping that person access services. If they're depressed, they may have a very hard time picking up the phone and making a phone call that they need to make.
All right. We go to Marion, who is calling us from Meyersdale. Marion, you're on the air. What's your question, please?
Well, I don't know if it's so much a question as it is a comment. Thank you so much for doing a show like this. I think it's enormously important for people to talk about suicide and talk about depression, because I think it's overwhelming. It's an overwhelming problem, I think, for a lot of people, for teenagers, for even younger than that, because they have no power in their life. My best friend of my whole life, I'm 67, he was 66. He just committed suicide, and it's been difficult for all of us to get through it, because he planned it. His wife announced that she wanted a divorce after 17 years. She wasn't happy with the situation. She was 15 years younger than he was. So, and I guess, he got into plus he's bipolar. She never believed he was bipolar. He took medication. He hated the way the medication made him feel. And I spoke to him the night before he did this. He came home to Pittsburgh area for a week to visit his brother, his mother, his whole family. They had a great time. He came to my house. He stayed over. We went out to dinner. We had a great time.
Did you feel like he was saying goodbye?
He was saying goodbye to everybody. And I said, what did he do different when he was here? You know what he did differently? He kissed me goodbye. He's never done that. We've been best friends our whole life, for the last 40 years. And he's never kissed me, because we're always very platonic. We're like brother and sister. He said, give me a kiss, I'm leaving. He kissed me on the cheek. I could not believe when his other friend from Las Vegas calls me a day later and says, Phil's dead. I couldn't believe it. His mother couldn't believe it. His brother, nobody could believe it, because he was so upbeat, but he did plan this.
That sort of goes with the earlier question. They seem like they're coming around. You had this great visit, and all of a sudden, what can you say about that, Dr. Durstein? How typical is Marion's story?
So there can be two factors playing into that. One can be that the person is actually showing improvement, and then they hit a difficult experience or a set of experiences that kind of brings the depression back. Other times, people have made a decision to end their life, and so there can be a resulting several weeks after that their mood appears to be much improved, because there's this weight that they may feel is lifted because they've made a choice.
And they want whatever it is that's been troubling them to stop. We often talk about this as a permanent solution to a temporary problem, but you treat people who have treatment-resistant depression. So for some, there is, finding the solution is not easy.
It can be long-term, and I think for many people, it can be a long course. And I think that's where really finding ways of being present and being with people sometimes without having to do anything, because sometimes family members don't know what to do. But being present and being available is we sometimes feel helpless, but that can be an incredibly powerful thing.
Well, speaking of feeling helpless, we talk about you and people who have survived a loved one who's committed suicide as suicide survivors. Mm-hmm. I explain that terminology, number one. And then I also wanted to talk about not saying committed suicide, but the preferred term would be died by suicide. Why is that also important?
Sure. So I think it's important when we're talking about terminology that we use died by suicide instead of committed, because there's often this negative kind of feel around the word committed. And so we want to make sure that it's kind of that we eliminate that and we reduce a lot of the stigma that's around it.
In fact, Dr. Gerstein said that the stigma is that it's almost a legal term.
Yeah, like you committed a crime.
A crime.
And that's not what it is. And so any way that we can start reducing the stigma around it and helping people reach out for help when they need it is really important. Just as, we talked about earlier, the word for successful suicide, there's no suicide that's ever successful. So once again, it's kind of using that terminology, died by suicide, or attempt of suicide.
I wanted to talk with you, Shannon, because sometimes families are well aware that a family member is really in crisis. Mm-hmm. The difficulty there is, do I convince them to voluntarily check themselves into to the hospital, or do they need to be involuntarily committed, a 302? Talk to us about that, because there are consequences of entering the hospital because of severe depression and suicidal issues that can be long-term.
One of the things that we want to really actually help families is, as Dr. Gerstein was talking about in regards to that sense of hopelessness and not understanding the illness, is providing education to families as well about, having them understand the illness and what to do, and having a plan of action if their loved one does become worse or becomes despondent, becomes severely depressed, and that the illness starts to take over some of the decision-making process that they have. So if we have a family member whose loved one is struggling, one of the things that they can do is that they never have to do that alone. They can outreach for help. And in our county, in our community, we do have our local mental health crisis line, which is Center County Can Help, and they can access that 24/7. They can also go to Mount Nittany Medical Center, to the emergency room, and they also can go to the Meadows Psychiatric Center. So we're actually very lucky here in our community in which there are different points of access for care, and when someone is in an emergency state, when they're in that crisis state, or that the family is looking to have intervention happen, that they can ask for help and intervention will come.
There are some who have said, I've read so many stories online where they said they presented to the hospital and they said, I'm in crisis, and because they didn't have insurance, they were turned away. And they said, without literally threatening suicide at the moment, that's what happened. And I'm curious to know, is that legal, for one, and number two, how common is something like that? Maybe I'll ask you, Dr. Gerstein.
In our hospital, no one would be turned away for not having insurance. There's part of what happens is an assessment in terms of the degree of risk that may exist. And so in terms of, we have inpatient criteria to meet the level of receiving inpatient care. So being actively suicidal or seriously suicidal at Mount Nittany won't, not having insurance won't keep you out.
Okay. I want to go to an email. This one comes to us from Jake, who writes, I've been affected by 2 suicides. Both instances, the person committed suicide in front of or in the proximity of one of their closest and most understanding friends. Is this unusual for people to do?
I would say that's relatively unusual. Suicidal behavior is actually fairly complex, and so there can be many different factors that can contribute to that. And sometimes there are folks that have issues around relating with other people, or difficulty in relating with other people, that may be part of the picture. And so sometimes interpersonal conflict can come into the picture. But I would say that's relatively infrequent. Can I follow up on
Sure,
a previous
absolutely.
point? So I fairly frequently hear families who may be very concerned about their family member, but at the same time be reluctant to pursue an involuntary commitment out of the fear of my loved one is going to be angry at me for pursuing this course. And I see that and hear that a lot. The flip side of it is that after hospitalization, for example, it's really a very short period of time until that person understands why their loved one took the actions that they did. And it's very rare that ends up being a long-term issue.
And 80% of people, according to the CDC, 80% of people who are suicidal are hoping that someone stops them. I don't know how we know that or how they know that, but that's what the CDC says. Shannon.
People ask for help. One of the things that we hear that is very stigmatizing to people is that we will hear individuals say that it's attention-seeking behavior or that this is a cry for help. And what we say is, so help. You know, the person wants help. They're asking for help. And so we want to provide that help for that person, whether it's acknowledging and validating what it is that they're feeling, whether it is that the family member asks for help and intervention to come. Either they call the crisis line, we go to the emergency room, we bring other family members in, we express that care and concern for that person and that we want to help them. You know, when someone is struggling with mental illness and we have the thoughts of suicide, that is part of that illness. That person's not thinking clearly. And we have to acknowledge that is there. And so we want to be able to get them the help. If someone fell and they were bleeding profusely, we would be calling 911. We would be going to the emergency room. We would know what to do. And so when someone is having thoughts of suicide, it's the same thing. They're bleeding. You're just not seeing the blood. But we need to help. We need to get intervention there.
Help us understand why men are so much more successful at committing suicide, and yet women attempt suicide perhaps as much as 4 times more than men. Dr. Durstein.
I think one of the factors of that has to do with the methods used. So men are much more likely to use firearms, and firearms are much more lethal than, for example, overdosing. Women are more likely to use overdose. And whether or not they're aware of how lethal the overdose may be is a secondary type of thing. A firearm is very commonly lethal. With regard to the whole question of suicidality, I make 2 assumptions. One is that everyone that has suicidal thinking has part of them that wants to live, and there's part of them that has these thoughts of dying. And so we try and ally with the part that is looking for a solution to what's going on. Most people will conceal those thoughts to a certain degree, and so it can be a real challenge sometimes to create an environment for them to feel comfortable to talk about what they're really thinking, and yet it is that conversation, it is that relationship that allows for that to happen.
If you're just joining us, I'm Patty Satalia, and this is Conversations Live, Understanding and Preventing Suicide. Our guests tonight are Marissa Versari, the president and founder of the John and Marie Foundation, Shannon Quick, chair of the Center County Out of the Darkness Walk to Fight Suicide, and Dr. Timothy Durstein, chair of Behavioral Health Services at Mount Nittany Medical Center. Our telephone number is 1-800-543-8242, and our panel is ready to take your phone calls. If you'd prefer to email us, our address is connect@wpsu.org. And we go now to Dick, who is calling us from Johnstown. Go ahead, please, Dick.
Yes, thank you. I'll direct my question to the doctor, and it doesn't regard in any manner any suicidal thoughts I may or may not have. But we live in a town here in Pennsylvania. We have a level 1 trauma center, and it's a teaching hospital. At this point, both of our psychiatrists have left for greener pastures, and I understand how difficult it is to recruit psychiatrists. Do you feel, as a first line of defense, a psychiatrist, to help the public, but specifically, would that jeopardize a teaching hospital's accreditation that presently we have no psychiatrists affiliated with a hospital? Thank you, Doctor.
I can't speak directly to the accreditation issue. I would say that not having adequate access to behavioral health, whether it's psychiatric services or therapy services, is a really significant issue that is not unique at all to this area. It's an issue across the country. And so one of the potential benefits of the Affordable Care Act has been to include substance use screening and treatment and mental health screening and treatment as a part of the core of what is expected to be assessed and treated. Over time, that hopefully will increase the numbers of mental health professionals that are available.
You look like you had something to add to that, Shannon. No. The loss of a psychiatrist in the community sounds like a pretty big loss.
I think I was agreeing with Dr. Durstein in that it is a national problem in regards to the shortage of psychiatrists and the barriers that prevent people from access to care. So in Pennsylvania, we have many, many rural counties, rural areas in which people have to travel quite a distance in order to get care, to see a psychiatrist. And people then are challenged with, do I go to work or do I go to treatment? And it is a juggling act, and people, that is a barrier at times, is how do I might need to go 2 hours away in order to see a psychiatrist.
But they might not hesitate if it was to go to see a heart specialist.
Right. And that's part of
so
the
that's
stigma.
part of the stigma. And so I'm going to take Joseph's call from Falls Creek in just a moment. But what can we do, Marissa, to help erase this stigma of suicide?
Sure. I think it's really educating ourselves. There's a bunch of different programs out there where we can learn more about suicide prevention. There's a mental health first aid for both adults and for youth. There's other trainings in the area as well. And I think the more that we can educate the community, the more that there's understanding, the more that we can help reduce those stigmas.
As a suicide survivor, did you and your family feel the stigma? Because sometimes people blame family members that someone took their life.
I think people don't always know how to approach the subject when somebody has died by suicide. So, I think as our family, we were helping Jana all the way through, trying to reach out to get help, and we did not feel it in our family. But from people outside of our family, I think a lot of it is, too, they just don't know how to approach the subject. We're okay to ask somebody if they notice a cast on their arm, what happened. But when it comes to something along the lines of a mental health disorder, we don't know how to approach that a lot of times, and we get nervous about asking those questions about how somebody's doing. So we felt that a little bit. But I think it's come up, I think we're starting to do more education, which is really helping reduce some of those different stigmas.
All right. Let's go to Joseph, who's calling us from Falls Creek. Go ahead, please, Joseph.
Yes, something that one of your guests said, and I'm curious. I understood that an attempted suicide was a crime, and the other thing, bipolar, I've never heard of a clear definition of what bipolar really is.
Okay, we'll begin with you, Dr. Durstein. What is bipolar disorder?
So bipolar disorder is an illness that not only includes the depressive phase of the illness, but typically the person will, at some points in the illness, have elevated mood, elevated energy. They may have risk-taking behaviors. There can be a number of behaviors that often the people around them will notice that's different than is typical. And so folks with bipolar disorder have a risk of suicide that's elevated both in the manic phase as well as in the depressed phase. The second comment?
He said he thought that suicide actually was criminal, and I know in some countries you can actually be sent to prison for get 5-year sentences for attempting suicide, which sounds nonsensical to me.
We do have the Mental Health Procedures Act. It's civil, it's not criminal. And so the Mental Health Procedures Act from 1976 was written to allow for treatment to be provided to a person who may not see the need for treatment, yet they may have a mental illness. And so there can be, we talked about a 302 involuntary commitment earlier, that can be compulsion for someone to come and be evaluated and treated, but it's not on the criminal side, it's a civil process.
Right. So I'm curious, Marissa, to talk a little bit about the LGBT community. When we talk about teens, they're most at risk. And so what role does rejection from a family or bullying in the schoolyard play in suicide among that population?
Sure. As Tim Durstein mentioned, anytime that there's that disconnect or that we're not feeling a sense of belonging, it puts us at a higher risk. And so bullying, harassment, rejection from a family member can all lead to that isolation, putting us at a higher risk.
You look like you had something to add, Shannon.
That actually also puts our older population at risk as well. That sense of belonging to a group.
It's so critical.
Right. So if I have thwarted belonging and I don't feel that I have worth or that I'm a burden to my family, that puts me at risk, for a higher risk for thoughts of suicide.
You know, when you look at teenagers, for every suicide, there are 25 attempts. When you look at the elderly, for every suicide, there are 4 attempts. Is this because elderly are less able to bounce back? I mean, so often if you're trying to commit suicide and by poisoning, for example, which is very common among women, is it because are the elderly more successful because they can't bounce back from an unsuccessful suicide?
Well,
I'm just curious to know why they're more successful.
Yeah, I think that they have so much more life experience, and I think many times they have gotten to the point, they look forward and they say, what do I have? And they are in the phase of experiencing many losses. And so they've thought it through. It's going to be much less impulsive, and so the results there are going to be more likely to be lethal in that population. The younger population, it's much more likely to be impulsive and not as well thought through, and so
an older person means business and they know how to do this.
And if they're males, they're using guns. So that's, and an elderly Caucasian male is the highest risk person.
And the older they get, and I hate to use the word successful, but I'm not sure how else to say, at completing a suicide. I want to go to Helen, who's calling us from Clearfield. Helen, go ahead. You're on the air.
I'm interested in knowing what the doctor believes, or what anybody believes on the panel, about the genetic connection to depression. Because I come from a family that there is depression throughout the family. I have major depression. My daughters have trouble with depression. I've got a grandson who's got problems with depression. I've got first cousins and second cousins and everybody else. It just seems to run in the family.
Dr. Durstein?
Yes, many psychiatric illnesses do have a very clear genetic family history component. I was expecting the caller to be asking about a genetic component with regard to suicide. And there is both an environmental component, in other words, people that are exposed to people that engage in suicidal behavior or do end their life by suicide. That does increase the risk of people in their immediate environment. But in addition, there is, separate from that piece, there is a genetic component that does put a subset of people at higher risk for suicide. We'll see family histories that, just like the caller's talking about, a family history of multiple people having depression in a family, that would be higher than what we would expect in terms of the average.
You know, and when you look at the Hemingway family, lots of suicide. You look at the what's the theater family? I can't think of it. Barrymore family,
Okay.
and you see lots of members have committed suicide. So you do wonder whether there is that link.
And frequently there's substance use illness in the family as well, which is also genetically, very genetically, that's an important part of the picture as well.
All right, we go to Bruce from Altoona. What's your question, please?
Yes, my question is primarily directed to the doctor. I'm just wondering, have there been any studies that show that post-mortem show any kind of chemical imbalance in the individual that may have committed suicide, or is that just something that isn't studied?
Yes, that has been studied, and there is evidence to suggest that there are alterations in serotonin levels in people who have ended their life by suicide. And so what I don't know clearly is many of those folks are depressed. In people who have depression, there's also frequently changes in various neurotransmitters in the body as well. So there are physical findings such as that are clearly present in a subpopulation of people who end their life by suicide.
You know, the Centre County Out of the Darkness Walk, which benefits the American Foundation for Suicide Prevention, has as its goal a 20% reduction in suicide by 2025. That sounds like an enormous achievement. What's it going to take to get us there, Shannon?
The American Foundation for Suicide Prevention set that goal this year. And really it's going to take research and evidence-based education, increasing awareness, anti-stigma campaigns, and just really starting the dialogue about reducing the number of suicides nationally. That we need to make it a conversation that we have. Our politicians, it's on legislation, that we really have to force that issue, and us as a community has to make that important, that we reduce this number.
I imagine, because you attend a lot of these events, when you talk with someone who has lost someone to suicide, have you learned anything about what's kept someone from taking that step? In other words, you know, when people get together who've experienced this and they know the impact that it has on families, and you say that the loss of one family member can have this ripple effect, at least 6 people are affected by that death. Mm-hmm. But does meeting together at events like Out of the Darkness, is that making a difference? And how important is it to survivors like yourself?
I think it's really important. You're around people who've experienced something similar to you, so you're connected. You're able to talk about it and not be judged and not have that stigma around it. It's education for people who might not be as familiar with it, and it's getting the community involved. And the more that we can get community involvement, the more we can lead to reducing those stigmas.
All right, we go to Buck, who's calling us from Clearfield. Buck, go ahead, please.
I have a question concerning soft suicide, and nobody seems to be addressing that in conversation tonight.
Did you say soft suicide?
Soft suicide, right.
Did you hear what he said, soft?
I'm hearing soft.
S-O-F-T.
S-O-F-T, okay, I've never heard the term. What do you mean by soft suicide?
Where they are intending to have other people or other situations end their life.
Okay, interesting, because you may mean by irresponsible behavior, driving like a lunatic with the top down and fast and that sort of thing, and causing an accident that would result in their death.
But it can be much more pronounced than that.
Okay. Any comments about that, Dr. Durstein?
Yeah, so the more indirect ways that people may end their life are much harder to get a handle on and to study. And we expect that there's a significant number of people who die by, for example, single car accidents and a variety of different situations that really were suicide events, but it's difficult.
They aren't documented that way.
They're not documented.
It looks like a car accident.
So in terms of risk factors, one of the things that we do look for is people who are engaging in risky behavior that is atypical for them. It's unusual, and it goes back to that degree of wanting to be alive and struggling with that. They may not be at the point where they can act themselves to end their life directly, but if I were to be hit by another car, or if I were to be hit on the road, or if I were to, there's a variety of different situations, the response is often, well, that would be okay. So there's direct suicidal thinking. There's also the behavior that people engage in that we refer to that as reflected intent. What is there that lets us know that the person is at risk, and we have to add together what they're saying and thinking to what their behavior is. And often those things added together give us a better sense of the risk.
Well, the interesting thing about this soft suicide that he's talking about is if you take your own life, that's one thing, but in a soft suicide, you can kill lots of innocent bystanders.
And I think that speaks to the notion that when people are in the state of mind where they're thinking about ending their life, their thought process is typically very distorted. And depression and a variety of other illnesses really do distort our thinking. When people are actively using drugs, their ability to use judgment, have good insight is often seriously impaired. And so they engage in behaviors that if they were well and doing good, they would not do. We were talking a little bit earlier about reduction, and I think the access to care is a major issue. Just like any other disease process, if it's addressed in a month or 2 or 3, that's one thing. Most of the people that I see, whether it has to do with addictions or mental health issues, they have already reached a stage that we would consider chronic before they ever present for treatment. And that makes the treatment process so much more difficult, and it makes recovery so much longer than it would need to be.
So the implications of that, if you see someone struggling, get them into treatment sooner rather than later.
Absolutely.
How do you get them to do that? Because there's so much denial, and in part because of what we talked about earlier, the stigma attached to it.
So I think one of the first things is being an active member in helping that person do that. They may have trouble developing or having the motivation to actually follow through. It can be a multi-step process of making an appointment, getting the insurance approval to actually be seen. It can be really a chore. I listen to some of the stories that my patients tell me, and it could be a challenge for someone who wasn't depressed, and yet in the context of their depression, they're trying to go through this, navigate this maze.
My guess is, Marissa, you experienced what he's talking about.
Oh, we definitely did, yeah. And it's hard. It's hard for the individual that's going through it. It's hard for the family and for anyone that's involved because you want to help them and get them the help that they need. But the processes can be difficult. It can be hard to know where to even begin. What is the first call that you should make? What resources are there available? So I think talks like this, too, that are identifying some of the different resources that are available in the community can be really helpful because it's giving a chance to be proactive. It's giving out some of those different resources that are here.
All right. William is on the line. He's calling us from State College. William, what's your question, please?
Yes. In the context, my father committed suicide, and the idea of this being, having some genetic component to it, of course, the environmental component as well, and depression and addiction and all these things have a genetic component. I'm wondering what advice or thoughts any of your panel members have on how you can talk about this with your family. I have a young family of my own. If these things are things that, you should be thinking about potentially being things to be aware of, how do you have those conversations with your other family members, whether they be your siblings or even your children?
Shannon?
I think a good place to start is through education. So, and we would have those conversations if we had heart disease in our family. And so maybe sitting down and saying, your grandfather, this is what he died of. This is part of the illness. This is something that we have to be aware of. This is what depression is. This is what bipolar is. You can go on SAMHSA, which is the Substance Abuse Mental Health Service Administration. It's our federal government website, which gives phenomenal information. And then having an honest question, answer, reading about all of those illnesses, and then talking about, okay, what do we do? We can be well. If we want to prevent heart attacks, we take an aspirin a day. We, watch our weight. We exercise. We do things. So to manage my depression, I may need to do those same things. I practice wellness strategies. I acknowledge in my family that this could be a potential. These are the warning signs.
And you want your children
Yes.
to be aware of warning signs,
Right.
that they may be in trouble. Is there ever an instance where you don't want to tell a child that a parent or a sibling died by suicide? Marissa?
I think at some point you will want to tell them the truth. Depending on their age, will depend on if they're able to understand exactly what happened. But you want it to be an honest conversation, and let them know that just because somebody in the family did have a mental illness or did die by suicide, it doesn't mean that there isn't this road of recovery. So, as Shannon mentioned, we can find coping mechanisms to help us. Just like if we're coming down with a cold, we might start by feeling a little bit of a scratchy throat. And so we start seeing some of those different signs and symptoms within ourselves. And we know, if I drink juice, it could help me. If I go out and exercise a little bit more, I can start feeling well a little bit sooner. And that same thing can happen with mental illness. We can start finding different things that will help us. Perhaps it's talking to somebody, or maybe it's doing some self-help strategies. And we can start implementing those and find that road to recovery.
All right. We go to an email. This one comes to us from Sue, who writes, "So far, I have only heard you discuss how to prevent suicide, but a local physician committed suicide several months ago, and it has left our community confused and lacking in quality specialty health care. What can the medical community do to help the patients cope with this tragedy?" Interesting, because, yes, there was a young doctor, a beloved young doctor. Lots of people relied on his care, and he's not here. What advice would one of you have for people who are struggling with the loss of this doctor?
As we've been talking, is talking to family members, friends, maybe doing a debriefing, which is having the community come together to discuss their own feelings about that, and understanding the illness in itself. And being able to address the complicated grief. When we have beloved community members die of any illness, we have to acknowledge the importance that they had in our lives, and talk about that. The last thing we want to do is suppress it and not acknowledge it. That's not the right thing to do.
Well, the interesting thing is, when someone takes their own life, you go through sadness and anger, and there's a whole range of emotions that you feel, whether it's a family member or someone like this beloved doctor in town. Well, what did you go through? And you're still going through it.
Yeah, and I think everyone's grief journey is going to be different, and you have to be the one that educates somebody in what your grief journey is like and what you need. So there's no standard grief journey, and you do feel every emotion. And there are times where all of a sudden it comes right back to you. You hear a song on the radio,
times.
And so you just have to be honest with those around you. You have to reach out for help if you are struggling. There's different support groups in town for suicide survivors, and also Tides is another great one that are here in town that offer that help.
And I think the interesting thing that email illustrates is suicide has no boundaries, gender, income, you name it. Anyone can be susceptible to suicide. I wanted to end with this because if we look at suicide statistics nationally, Pennsylvania ranks 31st of 50 states, which is pretty good when we look at other statistics for Pennsylvania. But that's still almost 1,800 suicides per year in Pennsylvania. So I want to end with this, Dr. Durstein. What takeaway message would you give to anyone who's thinking right now, you know, there's depression in our family that's not being attended to?
I think the whole topic of stigma is just really a big issue. The previous caller's question, I think, is a really good one. Suicide and depression and a variety of different illnesses affect across the spectrum. And often there can be ways in which people in the environment may see things or respond. But one thing I would recommend that everybody do is remove the guns from the home, because that is the one of the things that we can do to reduce the risk of suicide.
And in just a couple of words, Shannon, what's your takeaway message?
Talk about it, ask for help, keep asking for help, and use your voice, be the voice, and ask for help.
All right, and on that note, we are out of time. Thank you so much for talking with us. Our guests tonight have been Marissa Visseri, President and founder of the Jana Marie Foundation, Shannon Quick, Chair of the Centre County Out of the Darkness Walk to Fight Suicide, and Dr. Timothy Durstein, Chair of the Behavioral Health Services at the Mount Nittany Medical Center. I'm Patty Satalia. For all of us here at WPSU, thanks for joining us, and good night.